stop. Stop ignoring that top number on your blood pressure reading. Just stop. Because what you're about to hear changes everything about hypertension after 60. I'm Dr. Emma Whitmore, and after 3 decades as a vascular surgeon, I have stood over operating tables staring at arteries so stiff and scarred they felt like porcelain under my fingertips. I have opened chests where the heart muscle was thickened from years of silent strain. You think if your bottom number looks fine, you're safe. You're wrong. Here's what's actually happening inside your body. By the time I finish explaining this, you will never look at 150/70 the same way again. When Robert arrived at my operating table, his speech was slurred and the right side of his body was motionless. His systolic pressure in the emergency room was 182. His diastolic, 68. To understand how a 72-year-old retired mechanic who passed every checkup ended up with a clot lodged in his middle cerebral artery, I need to take you back 5 years. Robert did everything right. He took his medication. He walked every morning. His doctor reassured him because his diastolic number stayed below 80. What nobody told Robert was that every single heartbeat at 160, 165, 170 systolic was slamming into arterial walls that had already lost their elasticity. The culprit has a name: arterial stiffening. It doesn't announce itself with pain. It infiltrates slowly, like a siege army tightening its grip around a city that doesn't know it's under attack. Collagen accumulates, calcium deposits form, atherosclerotic plaque embeds into the wall. The artery loses its ability to expand when the heart contracts, so the pressure surges upward. That's the crime scene. When I operate on someone who has lived with elevated systolic pressure for years, I see thickened vessel walls, narrowed lumens, and tiny ruptures where high force has battered the endothelium. That's not theory. That's what the tissue looks like. It starts with repeated high systolic surges, which were caused by stiff, non-compliant arteries, which were triggered by age-related structural change that no one treated aggressively because the bottom number looked acceptable. Pause this video right now and think about your last reading. What was your top number? Write it down. I'm not giving you the worst part yet, because isolated systolic hypertension was once dismissed as a harmless consequence of aging. It isn't harmless. In adults over 60, systolic pressure is 2 to 3 times more predictive of stroke and heart attack than diastolic pressure. That's not a trend. That's a verdict. Robert didn't lose movement because of bad luck, not genetics, not stress, persistent systolic overload. And by the time symptoms appear, the siege has been underway for years. Here's what I see when I operate on someone who has lived for years with uncontrolled systolic pressure. The aorta is thickened and rigid, the carotid arteries are lined with unstable plaque, and the tiny penetrating vessels in the brain show microtears where pressure has punched through delicate endothelial lining. Exhibit A is not a symptom, it is structural damage. The perpetrator is not simply high blood pressure. The perpetrator is mechanical overload driven by arterial stiffness, amplified by neurohormonal activation, and accelerated by inflammatory signaling that your body never intended to keep switched on. Let's process this crime scene properly. It starts at the outer layer of the artery, where elastin fibers once allowed expansion with each heartbeat. Over time, collagen replaces elastin. Calcium embeds into the medial layer. The vessel loses compliance. When the left ventricle ejects blood, the surge has nowhere to go. Systolic pressure spikes. That spike injures the endothelium, the thin cellular barrier responsible for releasing nitric oxide through endothelial nitric oxide synthase. Nitric oxide is your vessel's peacekeeping force. It tells smooth muscle to relax. But repeated mechanical stress suppresses nitric oxide production. Now the artery cannot dilate appropriately. The battlefield tightens. Pressure climbs further. Your arteries are fighting a war they do not know they are in. The second mechanism enters here. Activation of the renin-angiotensin-aldosterone system, the RAAS cascade. When vessels stiffen and renal perfusion subtly fluctuates, the kidneys interpret it as threat. They release renin. Renin converts angiotensinogen to angiotensin I. Angiotensin-converting enzyme transforms it into angiotensin-D, a potent vasoconstrictor. Angiotensin II is not a villain by design. It is an emergency commander meant for short-term crises. But in chronic systolic hypertension, it becomes a general who refuses to stand down. It constricts vessels further, stimulates aldosterone, increases sodium retention, and thickens the vascular wall. The siege intensifies from within. A study from the Framingham cohort, published decades ago, followed participants for years and demonstrated that pulse pressure widening predicted cardiovascular events independent of diastolic readings. 2 to 3 times greater predictive power after age 60. Let me put that in real terms for you. If your systolic pressure sits at 160 while your diastolic rests at 70, your risk profile mirrors someone with far more obvious hypertension. That evidence has been sitting in the literature. Guidelines evolve slowly. Meanwhile, patients accumulated damage. When Patricia, age 68, came into my clinic, she complained of fatigue climbing stairs. Her blood pressure read 172/72. Her physician had adjusted medication modestly, but focused on avoiding low diastolic numbers. When she reached my operating room months later for coronary bypass, her left ventricle was markedly hypertrophied. To understand how she got there, rewind 7 years. She exercised, she limited salt. She trusted that because she felt fine, she was fine. What nobody told Patricia was that every elevated systolic surge increased afterload on her heart, forcing myocardial fibers to thicken. The law governing this is simple physics. Pressure times radius equals wall stress. Chronic wall stress leads to concentric hypertrophy. Hypertrophy reduces ventricular compliance. Reduced compliance elevates filling pressures. Eventually, symptoms appear. Not suddenly. Gradually. The absence of symptoms is not the absence of damage. Pause this video and check your last 3 home readings. Are they consistently above 140 systolic? Write them down. Do not skip this step, because I'm about to connect a third element that most clinicians discuss separately: inflammation mediated through NF-κB pathway activation. High mechanical stress on endothelial cells activates inflammatory transcription factors, including NF-κB. That pathway increases expression of adhesion molecules, attracting monocytes into the vessel wall. Those monocytes become macrophages, ingest oxidized LDL, and form foam cells. Now you have plaque formation superimposed on stiffness and RAAS-driven constriction. 3 coordinated assaults: mechanical, hormonal, inflammatory. A fortified city attacked from outside, infiltrated from within, and betrayed by internal sabotage. The SPRINT trial, published in the New England Journal of Medicine, enrolled over 9,000 patients and compared intensive systolic control below 120 mm/Hg to standard control below 140. The result was a 25% reduction in major cardiovascular events and a 27% reduction in overall mortality. Not a subtle effect, not a statistical curiosity, a verdict. Let me put that plainly. Lowering systolic pressure aggressively in appropriate patients prevented strokes, heart failure, and death. Yet I still see charts where a systolic of 158 is tolerated because the diastolic is 68. Your doctor is not careless. Your doctor is navigating evolving evidence. But the map changed, and if you do not understand the mechanism, the number looks abstract. Hold on, we are not finished. Because there is a third layer linking arterial stiffness and RAAS activation to cognitive decline. It involves microvascular damage in the brain and impaired autoregulation, and that connection is the one that changes everything. There is a third mechanism, and it is the thread that ties heart, kidney, and brain into one unified case file. Now we reach the third mechanism, the one most clinicians overlook until it manifests as memory lapses, confusion, or worse. Cerebral small vessel disease is the silent enforcer in the campaign waged by elevated systolic pressure. When the brain's delicate arterioles and capillaries are repeatedly exposed to high pulse pressure, the endothelial lining weakens, microbleeds form, and white matter lesions accumulate. The evidence is clear. Chronic systolic hypertension accelerates vascular cognitive impairment, dementia, and silent strokes. Researchers publishing in Stroke followed adults over 20 years and found that every 10 mmol increase in systolic pressure above 140 raised the risk of silent infarcts by 25%, independent of diastolic readings. This mechanism ties directly to the first two. Arterial stiffness amplifies pressure surges, RAAS-driven vasoconstriction maintains elevated baseline tension, and inflammation destabilizes microvessels. Together, these forces breach cerebral defenses, creating the hidden pathology that often surfaces only after irreversible damage has occurred. When Gerald, a 74-year-old retired school principal, arrived at my clinic, he had experienced a minor ischemic stroke that left his left hand weak and his speech slurred. On paper, his diastolic pressure hovered at 72, which reassured his primary physician. But his systolic pressure had crept into the 170s for years. Rewinding 5 years, Gerald exercised daily, followed a Mediterranean diet, and never smoked. He did everything right, yet his arterial stiffness progressed silently. His RAAS system was chronically activated, and NF-QB-driven inflammation had already begun embedding microlesions in his frontal lobes. This is the moment where controlled outrage is necessary. Patients like Gerald are not at fault. They followed medical guidance. The system failed to recognize that isolated systolic elevations carry far more risk than previously acknowledged. Pause this video and reflect. What's your top number doing when your bottom number is normal? Write it down, screenshot it, show it to your clinician. Now here is where hope begins. Here's what changes when you address all three mechanisms simultaneously. Arterial compliance improves, RAAS activity normalizes, and microvascular injury slows. Evidence from multiple trials, including SPRINT and SHEP, confirms that systolic control reduces stroke risk by 30 to 40%, lowers heart attack risk by 15-25%, and preserves cognitive function over years. The protocol I'm about to outline is not a list of suggestions. It is a targeted, mechanistically grounded approach. Component 1, lifestyle modification aimed at arterial elasticity. Aerobic exercise, brisk walking for 30-45 minutes, 5 days per week, combined with resistance training twice weekly, enhances endothelial function and preserves nitric oxide availability. Sodium restriction below 1,500 millilumens per day reduces extracellular volume expansion, lessening systolic load. Stress management through mindfulness or biofeedback downregulates sympathetic activation, the internal saboteur that otherwise amplifies a RAAS signaling. Component 2, pharmacologic intervention tailored to the three mechanisms. For many patients, a thiazide diuretic initiates volume reduction, ACE inhibitors or ARBs inhibit the RAAS cascade, and calcium channel blockers improve arterial compliance. Each dose is evidence-based. Hydrochlorothiazide, 25 mg daily, lisinopril, 20-40 mg daily, amlodipine, 5 to 10 mg daily, titrated to systolic targets below 130 mg. Not random, not interchangeable. The form matters. Extended release preparations ensure steady hemodynamic effect and minimize pressure spikes that damage microvessels. Component 3, anti-inflammatory and endothelial support. Nutritional adjuncts such as omega-3 fatty acids at 2 grams per day, alongside diet rich in polyphenols, support endothelial nitric oxide synthase function and counteract NF-QB-mediated inflammation. These components reinforce the vascular wall, slow microvascular injury, and synergize with blood pressure control. Another patient, Sylvia, age 70, illustrates partial reversal. She began the protocol after a mini-stroke left her slightly clumsy. Within 6 months, systolic readings dropped from 168 to 128 consistently. Echocardiography revealed a modest regression of left ventricular hypertrophy, and her neurologic function stabilized. This is the first glimpse of real agency. Knowing the mechanism allows intervention before catastrophic events occur. Now, before I give you the complete, I need you to pause and take action. Measure your systolic pressure 3 times over the next week, record each reading, and calculate your average. This data is your evidence, your case file. Screenshot it, write it down, bring it to your clinician or reference it as you implement the steps I just outlined. Understand this: isolated focus on diastolic numbers is insufficient. Ignoring systolic pressure in older adults is like ignoring the main assault force while trying to patch the walls under siege. The body attempted defense, yes, through vasodilation, baroreceptor signaling, and neurohormonal adaptation, but these defenses fail when arterial stiffness has entrenched itself. RAAS remains chronically activated, and inflammation destabilizes the vasculature. The tipping point often appears suddenly: minor stroke, angina, transient ischemic attack. But the crime has been unfolding for years. Ray. You will see how all 3 mechanisms can be addressed, how reversal is possible, and why the damage is not inevitable. Now I'm going to give you the exact protocol. But I need you to understand one more thing first. The synergy of the 3 mechanisms dictates that partial treatment is insufficient. Treat one, neglect the others, and you have slowed the process but not stopped the war waging in your vessels. This is why earlier detection, monitoring, and precise mechanistic intervention matters. Understanding this is the verdict. Knowledge plus action equals control. Here is the complete protocol, the sentence delivered to systolic hypertension and its silent accomplices, fully tied to the 3 mechanisms we have uncovered. Component 1, arterial compliance restoration. Aerobic exercise remains non-negotiable. 30 to 45 minutes of brisk walking, cycling, or swimming 5 times per week improves endothelial nitric oxide synthase activity, promotes elastin maintenance, and reduces arterial stiffness. Resistance training twice weekly adds structural benefit, countering collagen cross-linking and preserving vascular elasticity. Sodium restriction below 1,500 mg per day decreases extracellular volume, minimizing RAAS activation and mechanical load on the arterial wall. Meditation, deep breathing exercises, and biofeedback attenuate sympathetic overdrive, blunting neurohormonal contributions to elevated systolic pressure. Component 2, pharmacologic intervention, strategically targeting RAAS, vascular tone, and pressure spikes. Start with a thiazide diuretic, hydrochlorothiazide, 25 mg daily, to reduce intravascular volume. Add an ACE inhibitor such as lisinopril 20-40 mg daily, which suppresses angiotensin II formation, reduces aldosterone-mediated sodium retention, and directly limits RAAS-driven vasoconstriction. In patients intolerant to ACE inhibitors, an ARB like losartan 50 to 100 mg daily is equivalent. Complement this with a long-acting calcium channel blocker, such as amlodipine 5-iron 10 mg daily, which relaxes smooth muscle in stiff arteries, dampening systolic surges and enhancing microvascular perfusion. Dosing is critical, timing is critical, and extended-release formulations ensure a steady effect rather than episodic peaks that can injure the endothelium. Component 3, endothelial and inflammatory modulation. Omega-3 fatty acids, 2 grams per day, combined with a diet rich in polyphenols, berries, dark chocolate, leafy greens, support nitric oxide production, stabilize endothelium, and inhibit NF-κB-mediated inflammatory signaling. These steps directly target the 3rd mechanism, microvascular injury in the brain, heart, and kidneys. Now let's examine objections from the courtroom. Some of you are thinking, my doctor will disagree. Screenshot the Framingham and Sprint study findings I cited. Present them as evidence. Most physicians will engage in conversation when you show the mechanistic rationale, not as a challenge but as a data-driven dialogue. Others worry about cost. Compare the price of daily medications and nutritional supplements to the expenses incurred from a stroke hospitalization, cardiac bypass, or dementia care. Tens of thousands of dollars versus a few dollars a day. Some ask, will this work for me? Biology does not discriminate. The same arterial stiffness, RAAS activation, and inflammatory pathways run in every human body. Differences are in timing, duration, and damage extent. The sooner you start, the more reversible the effects. And no, taking only one component is insufficient. The three mechanisms are interdependent. Ignoring one leaves the assault force operational. Now meet Raymond, 76, a retired engineer, full reversal in action. He had isolated systolic hypertension for 8 years, with systolic readings above 165, diastolic 70, left ventricular hypertrophy, and early cognitive slowing. Following the protocol, his systolic dropped to 126, left ventricular mass regressed measurably on echocardiography, and neurocognitive testing improved after 12 months. This is what control looks like when all mechanisms are addressed. Now the CTA cascade. Before you do anything else, leave a comment. Tell me how long you've had elevated systolic readings, your last recorded top number, or what prompted you to watch this video. Every comment tells YouTube's algorithm this case matters, and I read them to guide future videos. Next, share this. Not just to your feed, text it to anyone over 60 who has elevated blood pressure, a parent, or a friend who trusts the bottom number over the top. Somewhere, someone is in the early stages of what Robert, Patricia, Gerald, Sylvia, or Raymond endured. Subscribe to this channel and turn on notifications. The next video covers vascular stiffness reversal and microvascular repair. If you miss it, your protocol is only half as effective. I've also put together a complete case file, exact studies, specific forms and doses, and the step-by-step protocol in a single reference document. Download it from the link in the description. Bring it to your next appointment. Before you go, one comment. Type stop. If you're committing to controlling your systolic pressure today, already, if you knew part of this but not all, or SEND if you're forwarding this protocol to someone right now, one word, that's all I need. One more thing before you go. There's another case on endothelial repair after chronic hypertension that directly impacts cognitive outcomes. Click the video on screen now. Understanding it completes the picture of vascular resilience. With this protocol, you now have what your doctor wasn't trained to give you, a precise, mechanistic, evidence-based path to reducing risk of stroke, heart attack, heart failure, kidney damage, and vascular cognitive decline. You are now empowered to act, not just observe, and the sentence for elevated systolic pressure is clear: control, reverse, and protect.